Effectiveness of mindfulness-based relapse prevention in individuals with substance use disorders. A systematic review. This was printed in Behavioral Sciences, written by Eduardo Ramadas, Margadeo Pedrosa de Lima, Tanya Cateno, Jessica Lopez, Maria dos Anjos Dixie. It's printed in the National Library of Medicine, October 11th, 2021. Abstract. This systematic review aimed to understand the current state of the art about the effectiveness of mindfulness-based relapse prevention, MBRP, on individuals with substance use disorders, SUD, taking into account not only SUD variables, cravings, frequency of use, but also other relevant clinical variables, anxiety and depressive symptoms, quality of life. Methods. A comprehensive search of electronic databases was conducted to identify studies and investigate MBRP interventions on individuals with SUD. Studies that met the inclusion criteria were synthesized and assessed using systematic review methods. Results. 13 studies were included in the present review. The methodological quality of the included studies was moderately strong. 9 studies, 69.2%, used the traditional 16-hour MBRP program. 6 studies, 46.1%, chose to use a co-intervention treatment ranging from the treatment as usual to cognitive behavioral therapy. All but 1 study indicated that their interventions produced positive effects on at least one addiction outcome measure. None of the interventions were evaluated across different settings or populations. Conclusions. Despite some heterogeneity regarding the type of MBRP program used, results support the effectiveness of these interventions in the SUD population, especially in reducing cravings, decreasing the frequency of use, and improving depressive symptoms. 1. Introduction. Substance use disorders affect the lives of more than 35 million people worldwide, according to 2019 data from the United Nations Office on Drugs and Crime. A chronic disease, substance addiction, is associated with significant costs, not only for the individual, but for society at large. It often starts with occasional substance use in a recreational context, followed by a progressive increase in frequency of use as the desired effects are diminished by habituation. This process is mediated by genetic, developmental, and psychosocial factors that impact an individual's relative vulnerability to the development of an addiction. Although there are many different types of SUD, depending on the main substance of choice, with DSM-V offering diagnosis for the abuse of alcohol, cannabis, hallucinogens, opioids, and even caffeine, among others. There are underlying mechanisms in addiction that appear to be common to all substances. Given the prevalence and manifest individual and socioeconomic consequences of substance addiction, there has been a considerable effort by the scientific community to create and study effective treatments for SUD. Despite this, relapse rates remain incredibly high, with data suggesting that more than 2/3 of individuals return to substance use within a year of treatment. The relapsing nature of substance addiction has made it clear that relapse prevention is an essential treatment component for long-term recovery, shifting attention to interventions that propose to address this need. The most common intervention targeting relapse prevention is based on the identification of idiosyncratic high-risk situations that can increase the probability of relapse, and the development of specific strategies that the individual can resort to when exposed to them. However, recently other types of interventions aiming to improve the effectiveness of SUD treatment and address relapse prevention have been emerging, as is the case with mindfulness-based interventions. Mindfulness is a mental state that involves an awareness of the present moment and a non-judgmental posture towards internal and external phenomena. Practicing mindfulness has been shown to help regulate attention, cultivate acceptance, and develop the ability to observe inner experiences, thoughts, feelings, and physical sensations without judgment. In the context of addiction treatment, it can promote awareness of external and internal triggers for addictive behaviors and improve tolerance to uncomfortable emotional, cognitive, and physical experiences. It can also have a significant effect on decreasing cravings after treatment. Mindfulness-based relapse prevention, MBRP, is an intervention that integrates mindfulness meditation with traditional relapse prevention techniques. It has three main components: formal mindfulness practice, informal practice, and coping strategies. The formal practice includes body scan, sitting meditation, breath, body, thoughts, and emotions, mountain meditation, and loving kindness meditation. The informal practice includes urge surfing, mindfulness of daily activities, sober breathing space, and mindful movement. Some of the informal practices can be used as coping strategies due to the fact that they can help the patients cope with difficulties, emotional challenges, or stress. As such, this last component intends to adapt informal practice into practical strategies the individuals can use in real-life situations. The original MBRP program has a total of 16 hours divided into 8 weekly sessions of 2 hours each, but can be adapted according to the target population and the researcher's goals. The sessions include mindfulness practices and exercises that aim to increase the individual's awareness of internal, emotional, and cognitive, and external situational cues related to substance use, and help in the development of appropriate coping strategies. The first 3 sessions of the program focus on raising the individual's awareness of environmental triggers and reactions that may occur in response to them. The first session centers on the individual's habits, which occur in autopilot mode. The second centers on increasing the awareness of triggers and cravings. And the third centers on the promotion of mindfulness practice in daily life. Sessions 4, 5, and 6 focus on mindfulness in the context of relapse prevention. The fourth session centers on the use of mindfulness in high-risk situations. The fifth session intends to teach acceptance and skillful action. And the sixth session centers on the concept of diffusion, that is, the ability to see thoughts only as thoughts and not reflections of reality. Finally, the last two sessions focus on social and environmental factors and have the goal of guiding the application of what is learned to everyday life. The aim of this review was to evaluate the effectiveness of MBRP in individuals with SUD. Although the search conducted on the Web of Science and Cochrane database of systematic reviews revealed the existence of a systematic review meta-analysis looking into the same question, we considered that the interest this topic has gathered in recent years justified another review. It is not only likely but probable that in the 4 years that have passed since Grant and others conducted their review, new relevant studies have been added to the literature. Given the rapid growth of knowledge concerning this type of intervention, we also hope that more recent studies have taken into account some of the limitations found in their earlier counterparts. To better understand the effectiveness of MBRP in this population, we considered the following questions. Do MBRP interventions lead to significant improvements in SUD variables? Example, cravings, frequency of use, in individuals with SUD. 2. Do MBRP interventions lead to significant improvements in other relevant clinical variables? Example, anxiety, depression, quality of life in individuals with SUD. 3. How do MBRP interventions compare to other evidence-based interventions for individuals with SUD? Discussion. The objective of the present review is to evaluate the effectiveness of MBRP on individuals with SUD. A majority of the included studies found significant improvements in at least one SUD or clinical variable following an MBRP intervention. This was true not only for studies that used the original MBRP program, but also for those that chose a modified version. Example, different program length or session duration. Regarding the impact of MBRP on SUD variables, the results indicate that participants that received the intervention had a significant decrease in frequency of use, both measured by days of heavy drinking and number of drinks per day for alcohol, and number of using days substance misuse for other substances. There was also a significant decrease in cravings, desire to use, withdrawal symptoms, and probability of relapse. Concerning other clinical variables, the results suggest that participants who received an MBRP intervention saw a significant decrease of anxiety and depression symptoms, as well as reduced impulsivity levels. Moreover, they showed a significant improvement in quality of life and coping capacity over time. These findings seem to be congruent with the subjective experience of the participants, which is found by Zergarska and others, presented an overall satisfaction with the intervention and believed it to be helpful for their disorder. Only 3 studies chose to apply the MBRP program without a co-intervention while providing a comparator group. 2 other studies used TAU as a co-intervention and comparator. This made it difficult to properly compare the effectiveness of MBRP against that of other evidence-based treatments. Still, the results are relevant to understand if new knowledge on the relative effectiveness of MBRP has been created since the last systematic review conducted by Grant and others. Supporting the conclusions from the previous review, Zagarska and others found that MBRP plus TAU was not more effective than TAU in individuals with alcohol dependence. Even though there were no significant group differences, it should be noted that individuals from both groups showed favorable outcomes. On the other hand, Rose and others, and Zemastani and Ottavani also compared MBRP with TAU and found different results. Rose and others reported an interaction by affective symptoms that predicted increases in approach coping, which in turn led to more favorable substance use-related outcomes. Example, fewer heavy drinking days and substance use problems at 12 months. The mediator effect of increased approach coping was only found for individuals with high baseline affective symptoms, as opposed to low or moderate. Similarly, Zemastani and Ottaviani found that MBRP was significantly more effective than TAU in reducing rates of depression, anxiety, and cravings in individuals with SUD and comorbid depression. Finally, Greenfield and others compared the most used forms of relapse prevention with MBRP and found significant differences regarding the decrease of frequency of use. The results from the studies by Roos and others and Zemastani and Ottaviani are particularly interesting. They indicate that MBRP may be especially useful for individuals who present with SUD in comorbidity with severe psychiatric symptomology, namely those with affective disorders. This could be explained by the impact mindfulness has been shown in facilitating emotional regulation. Fosel and others, for example, have proposed that the effects of mindfulness are a result of changes in mental and brain functions pertaining to, among other self-regulatory systems, attention and emotional regulation. Similarly, Virgo Silberswag suggested that changes in self-regulation and self-awareness resulting from mindfulness reflect modulation in neurocognitive networks associated with various dimensions, including emotional regulation. Some authors have even argued that mindfulness might employ a unique strategy of emotional regulation based on bottom-up systems, contrary to cognitive reappraisal, which relies on top-down systems. Bottom-up pathways are thought to be responsible for emotional processing, generation of arousal and effect, and have been linked to some limbic regions and the striatum. Interestingly, bottom-up along with top-down processes have been hypothesized as possible mediators to the effects of mindfulness practice on SUD. This is at least in part explained by the role these and associated pathways are proposed to play on the reactivity to drug stimuli, drug cravings, and relapse. Despite their believed relevance, so far these pathways have barely been researched. As with all studies, the present review has limitations that need to be considered when interpreting its results. It's important to highlight the presence of methodological weaknesses in some of the included studies, such as reduced sample size in those using a quasi-experimental design. Given that these weaknesses can skew the results obtained, it is not possible to generalize them and conclude the effectiveness of the intervention under study. Another aspect to consider is the significant heterogeneity found between studies in relation to the main objectives, target population, and type of intervention, which invalidated the option of conducting a meta-analysis. Beyond the characteristics of the studies included, another limitation of the systemic review was the reduced number of databases used for the article search. A broader search might have led to the discovery and inclusion of more studies, and as a result, a more complete account of the current state of the art about this subject matter. In conclusion, we believe the results of the present review indicate that MBRP has a significant positive impact on various substance use and clinical variables. Moreover, even though we could not properly evaluate the comparative effectiveness of MBRP in relation to other evidence-based treatments, the results suggest that this intervention may be of particular value to the treatment of individuals with SUD and comorbid psychiatric symptomology. Further studies should not only continue to investigate the effectiveness of MBRP in individuals with SUD, with and without psychiatric comorbidity, but also explore possible mediating variables that may allow for a better understanding of it. Furthermore, we believe that future research into the effectiveness of MBRP would greatly benefit from considering neural measures in order to deepen the knowledge of the neural circuit mechanisms involved in the practice of mindfulness and how these relate to relapse prevention. There are few studies that considered neural responses in their results, with only one study of interest in this area.